Okay, everyone, my name is Ash McCaskill. I am the programs coordinator for Age Well and the EPIC AT program. I am a white woman with short brown hair and green eyes. I wear glasses that are cat-eyed, that have kind of a greenish blue and white kind of frame around them. And I'm wearing a red dress today. I will first just go through some of the access points, and then I will bring it over to Dr. Robin Tamblyn to introduce our speaker today. So thank you so much. So just some access points. Please know that today's webinar is being recorded and will be available on the AgeWell website after the event. If you do need closed captioning, please look at the bottom of the Zoom screen. You will see that there's an icon that says closed caption with 2 C's. You can use this, and as we speak, there'll be like an automatic transcription of what we're saying, and it'll appear in a black box with white text. But please know that it is automated, so sometimes there will be some inaccuracies. We do want to ensure that everyone has a good experience today. And so for this reason, we ask all speakers and attendees to show respect and kindness in the chat and also in the question area. If anyone does show any form of harassment, we will remove you from the event. We do encourage you to share your thoughts, comments, any resources. So feel free to use that chat that's open to you all. And I will be moderating the chat today. So if there's any questions or support that you need, I will be available. And we will invite you to share where you're coming from today. And I will now pass it off to Dr. Robin Tamblyn to introduce our speaker today. And thank you so much, Robin and Yves, for being here.
Okay, thanks very much. And I'm really thrilled to be able to introduce Dr. Yves Joanette, who I've known for, I don't know, I think probably 8 or 9 years, if not more. So Dr. Joanette is a professor in the Faculty of Medicine and the Deputy Vice Principal of Research at the University of Montreal. He's previously served as the Scientific Director of the Institute of Aging at the Canadian Institute for Health Services Research. He's been the Executive Director of the CIHR International Collaborative Research Strategy on Alzheimer's disease and the Chair of the World Dementia Council. Dr. Joanette's research interests include the cognitive neuropsychology of aging and communication disorders. Using novel cognitive and neuroimaging approaches, he's contributed to the advancement of knowledge regarding the neurofunctional reorganization that allows for the maintenance of communication skills with age, the effects of lesions in the right hemisphere of the brain on these skills, and cognitive disorders in Alzheimer's disease. It's really a real pleasure to introduce Dr. Joanette personally, because he and I worked together for at least 8 years at the Canadian Institutes of Health Research. He's got such a big vision that I'm just thrilled that he's going to kick off the health policy series. Now for today, Dr. Joanette is going to speak for about 40 minutes, giving us his vision. And please put your questions in the chat. At the end of his presentation, you can raise your hand to ask questions, and please don't be shy, because this is a once-in-a-lifetime opportunity for you. So raise your hand, and that's at the bottom of the screen, the little raise hand icon. Or put your questions in the chat if you're not feeling comfortable just speaking to the rest of the group. And we will iterate your questions and get them a response to them. So with that, I'm going to turn it over to Dr. Joanette, and I just really look forward to this session. Thank you.
Merci beaucoup, Robin. I'll use Shakespeare and not Molière as the language here in order to optimize communication. And in order to optimize contact, I'm an older man with a blue shirt and a bow tie, which is my trademark. And if you can see me, you see that there's books in my office there in the back, and those black books are in fact dissertation and thesis, part of them from my students. So I'm here with my students in the back of me. And I would like to, I'm very happy, and thanks to AgeWell and EPIC AT for the invitation. And maybe just an anecdote before starting, because some weeks ago, I was with the CEO of the hospital that is in charge of the Institut de Gériatrie, the Geriatric Institute. And he was like 3 weeks ago, I met with him in the afternoon, and in the morning he was with the Minister of Health and Social Health in Quebec. And he was telling the minister that given that his hospital is responsible for home care, there was no way that the hospital could have the resources of people to provide home care for the increasing number of older people that will age at home in the near future. And so he told me that he told the minister that the only way to go will be e-health. And I said, well done. And that's what I would like to share with you today, some thoughts about how what has been developed in Canada, among others through Age Well support, in terms of technology, could be used in order to deploy to all those who want to live at home a support for monitoring, for intervention, and how, as my title tells it, how deep space health might be helping us in finding solutions. So this is what I'm going to talk to you about today. And I cannot not start, and sorry, I'm going to put this in full screen. I cannot not mention here that, well, the world is aging, and you know that. And you can see here the classical small video where you see dark blue countries popping, and these are super aging countries, those where 60 years and older represent 30% or more of the population. If you had the good blink of the eye, you saw that we started only with Japan, and now in 2050 we'll have more than 50 countries with such older proportion of people. And just as a indicator, this is the number of centenarians in Canada projected over the next years. And as you see, the baby boom is followed by a centenarian boom here. And there is a major increase in the number of centenarians that is going on and is expected to accelerate. So it's not only a question of getting older in terms of life expectancy, it's also that there's more and more people getting near the oldest portion of the spectrum. And as, of course, as you can see here in dark blue, it's a minority of men and a large majority of women that will become centenarians. And another indicator is the crossing between the two curves here, a red one and a blue one. And as you see here, some years ago, the curves crossed each other. And this means that, in fact, the absolute number of 0 to 14-year-old in Canada is now smaller than the absolute number of 65 years and over. So all these are indicators that the population is aging. So you'll say to me, yeah, but I read articles saying that, for instance, here in the British Medical Journal recently, last autumn, that the COVID had an impact on life expectancy and premature mortality in 2020. And there is indeed a little dip in the life expectancy that is expected, so to say. And here you see very recent papers in the BBC showing that the US life expectancy falls to lowest levels since 1996, that China's population falls for first time since 61. All this is true, but it won't change the fact that the number of older people will increase and the proportion of older people in the population will increase. So there will be more and more older people. And here I'm using pictures from this website of Ariane Clément, a Canada and even world recognized photographer of older people. And I invite you to look at her pictures. And one thing that strikes here is that, apart from the beautiful pictures, is that there's diversity, right? Not all older people are the same. In fact, I frequently mention that two newborn babies are probably more similar than two 70-year-olds or 80-year-olds, which are very different according to their life trajectory, according to many aspects. And so this diversity, I sometimes represent the diversity by the contrast between the different ages we can use in order to qualify ourselves. So for instance, this is what I call the passport age. So this is like according to our passport, if we live 56 years, well, we're all 56-year-old, right? There's no difference. And the three persons symbolized on this passport age picture here, the yellow person, the red person, and the blue person, the blue lines, they all have the same passport age according to the fact that, you know, time goes by. But that's not the reality of things. The reality of things is that some people, like here, the yellow person, even though the passport age is at one level, maybe her or his cognitive functional age will be older, and maybe that person will develop neurodegenerative diseases. The blue person here is more or less like the passport age, but the red person here is probably, even though older in terms of passport age, will be younger in terms of brain or cognitive or functional or body age. So that we probably have different ages, which by the way has a impact. If we were in France today, and in fact I gave such a conference in December in Paris, where there's lots of discussion on the age of retirement. Well, if you put an age according to the passport age, it's not really relevant. We should move towards a functional age for retirement, because some people are aging earlier because of the kind of work they've been doing, because of the kind of health they have. Now, one thing that is very important is that as we age, and so this picture here shows on the bottom, you know, the age, and you see different lines adding to each other, right? Well, these lines, they symbolize the fact that a given person at a given age or a certain proportion of older people have a number of health conditions. And in fact, it is known that between 65 and 75, there's about 35% of the population which has 3 and more health conditions. Now, this does not mean that the person has to go to the hospital or long-term care center, because this can be monitored, this can be treated by pills, by activities, by nutrition, and so on. But it means that they're more frailty. It means that they have to be monitored and looked at. In fact, at 85, it's 65% of the population of 85 and plus that has 3 and more chronic conditions, diabetes, arthritis, and so on. Again, not something that is interfering with the possibility to, let's say, live at home, but needs to be probably monitored. And just by the way, what we understand today is that why do we see this accumulation, this addition of multiple of chronic condition with aging? Well, in fact, there is something called a geroscience, which now makes the link between the biology of aging and the interaction with the different systems that makes it such that a given person will start with arthritis, then will go to diabetes, then will go to neurodegenerative diseases, if so, or the other one will do it in the other way. But there is more and more understanding that there are common processes, and there is currently clinical trials in order to try to address those basic biological aging processes that will help prevent all the multiple chronic diseases associated with aging. But this is simply an information for you. So let's go back. One thing that when I was at the Institute of Aging, we went across Canada. We heard what people were saying, and you know, and I'm not here talking only about older people. I'm talking about the whole population. When thinking about when you will be old, if you're like most Canadians, the biggest fear you will have, or you have probably, is to develop something like Alzheimer's or dementia. That's really a big fear for the population. It is a priority. But the second priority is to be able to age at home, whatever home is. Maybe home is the home where you were born, or home where you moved, or a protected home, but it is to be able to age at home. And the third one, Robin, is access to healthcare services. So it's it's the three. So if we sum up until now what I've been saying, I've been convincing you that there will be more and more aging Canadians, that many of those Canadians will live with multiple chronic diseases, and that they will be expecting to live at home, which will require support like monitoring intervention. Remember the CEO I just mentioned before I present my slides. Now, it is true that the large majority of older people, they live at home. Sometimes we think, long-term care centers. No, it's less than 10% of 75 and plus that live in long-term care center. So 90% live at home. And only approximately 10% in, so to say, protected environments. The 80 or 70%, they live at home, whether an apartment, a home, and so on. So those older Canadians living at home with multiple chronic diseases and loss of or partial loss of autonomy, they will require follow-up in order to monitor their health and wellness status, and to receive some intervention or support at distance. And this is where there is no way that this will be done only by humans taking their car and visiting people at their home. So, and this and just looking at the AgeWell website, there's many projects talking about smart homes, tele-diabetes care, wearable technologies, monitoring health data, and so on and so on. So I mean, there's a lot of good research going on. For instance, this one, again, taken from the website on wearable device supports residents, staff in seniors' home and assists with contact tracing, for instance. And you will hear from me that among the technology, I have a personal preference for those wearable devices, and particularly the intelligent garments, which in fact are extremely integrated. But there are all other stuff as well. Again, and then there's technology that has been developed in order to be present at distance in those homes if some conversation and intervention is needed. And this is exemplified by this summary that the active assisted living group, to which AgeWell and CIHR are members. This is a Europe program. And this is like a cartoon that was created some years ago, just alluding to those multiple potential sensors and devices that can help people at home. So there's a lot of work to be done as well, but there's a lot of those sensors that are available, and congratulations to all of you if you work on that, because that's very important, but it is not enough. And of course, that you have to be present, or you have to be able to visit the home if there's something. And here I used on the left side the remote presence robot used in patient care, something I picked up in a AgeWell report in 2018. And on the right side of the slide, you see myself with my friend, the giraffe, which is such a telepresence robot. Just imagine this device being just left in a house. And when the nurse or the health professional wants to visit the house, they just pop up on the screen. The robot can even move, go. There's a camera, so it's very basic technology, so to say. It's like a movable iPad with a camera and so on. But the reason why I like the giraffe is that this device has been, and to my knowledge is the only one, has been integrated in the health system in Sweden. as a way in the health system to allow nurses and health professionals to visit home. And they have snow in Sweden, and we do have snow here in Canada, and we have long distances. So I think this is also technology which is important. So we have sensors technology, we have technology that, and of course, I'm not saying that we should stop doing research on this, but we have lots of potential on sensors, we have lots of potential on telepresence. And given that there's a growing needs to monitor older people living at home with multiple chronic conditions, with technology that is integrated in the everyday life activities, we can say that such a monitoring has to be available for all Canadians with such conditions, wishing to live at home, wherever they live, wherever home is. It has to be connected to the health system. That's the big problem, well, the big challenge currently. And it has to be followed by means of having rapid visit, for which telepresence technology represents a first step. So where I'm going is that I'm going to the fact that older person with multiple chronic conditions living at home, they should be having access to comprehensive integrated wearables. It should be connected with the health system, which should have a way of monitoring this, which will induce a rapid tele-first response in order to help these people to maintain being at home or to take decisions and have them in the health system if there's a big problem. But we see here that this dynamics it has to be put in place, but it's not there. We have the technology, we don't have the rest of the dynamics. And this is where my link with space is coming. So why space? So when you saw the title of my talk, you probably said, well, what's the relation with deep space exploration? Well, the relation is the following. Canada and the Canadian Space Agency has been publishing and having expert groups thinking about how Canada could help the deep space exploration. I'll come back to what is deep space exploration, but it's essentially illustrated by, let's go to Mars, right? That's the deep space exploration. And so there's different reports. Alex Mihailidis and myself were part of those expert committees. I think Alex is still a member. I participated in this report that can be found on the internet on the left side here, March 2019. There's a more recent one on the right here. But this was really an expert group thing. And what we see here is a picture of a meeting with a number of experts. I'm seated with Alex Mihailidis at the end of the table. We had discussion with the president of the Canadian Space Agency here, providing our results. Diane Côté, the CEO of MedTech, is on one side of the table. Bob Thirsk is also there, an astronaut who was also serving as VP at CIHR. And as you see, there was a lot of discussion. So what were the discussions about? Well, first of all, you have to know that the international space ecosystem pointed to Canada, saying, Canada, you should be in charge of the health for those deep space exploration. So Canada has somewhat accepted to be in charge of the health of going in deep space. And at the same time, Canada said, well, okay, if we do that, but we hope it's not going to benefit to the happy fews that will go to Mars, and that it will benefit to the whole population of Canada. So let's backtrack and see what's the challenge here. Currently, that's the International Space Station, right? As we see it every morning. No, I mean, that's the International Space Station. And this space station is, let's say, near Earth. It's, circling Earth. It has a number of problems. It's going to be finishing its life in about 8 to 10 years or whatever, or 5 6 years, but it's been used a lot. And what's happening when if there's something which requires health intervention in the currently used International Space Station? Well, what you have to know is that the International Space Station has a number of capsules which are always there. You see here the Soyuz MS-22, I think that's the one. So that's the ambulance. If someone has a health problem, needs an appendicectomy, I don't know, in the space station, they won't do that in the space station. The person will be put in the Soyuz MS-22 and will be brought back to Earth very quickly. And what I'm told is that, between the time you open the door to the capsule and the time you open the door to the university health center, at the hospital, there's about 23 hours. So there's about 24 hours, of reaction. So that's good. I mean, that's good. If it needs a more rapid intervention, then it won't be good. And there's a way of facing this, but essentially, this is how it works currently. And again, I'm not talking here on behalf of the Canadian Space Agency or the NASA. I'm just sharing with you what I understood from how it works now. However, if we go to Mars, then it's completely different. First of all, there will be on the left side of the slide here, you have this International Space Station. Now, the project for the 2020s, and we are in the 2020s, and in fact, as you saw, the Orion rocket tests were completed recently, and if something went around the moon and came back. So the next step is to create a kind of a gateway station that will circulate around the moon, that will be where the Mars people or rockets will fly from to go to Mars. So it's not a situation where you can say, oh, there's a health problem, I'm going to jump into a capsule and be brought back to Earth. That's impossible. And in fact, if there's something going on wrong when you're on your way to Mars, you have to understand. Well, we have to understand, and they know very well, it's about a 2.5 year trip. So, and there's lots of delays, even if you do a kind of an internet or virtual assessment. So the conclusion here is that deep space exploration will require autonomy in health. Autonomy in monitoring and autonomy in reacting to the monitoring. Unlike what has been done currently in the space station, because there's no autonomy of health, well, just for real emergencies. And people can be brought back. And so what did the NASA and the Canadian Space Agency did? Well, they already looked, well, first of all, here you have some, I'd like to share some wordings from the reports. By leveraging Canada's health and medical research expertise and emerging technologies such as AI, Canada will advance autonomous medical systems to support astronaut health in space and health outcomes at home. Through the Lunar Gateway project, that's the Around the Moon, and via new efforts on Earth, Canada will explore the questions key to improving healthcare and quality for Canadians. So you see here the relationship between deep health and space health, and it is like, and these are again are extracts from the official Canadian Space Agency reports saying, onboard medical systems will be more intelligent than healthcare delivery equipment in any previous spacecraft. digital information networks will incorporate crew-worn sensors. So, you make the link here, and the monitoring of the crew activities and so on and so on. Onboard computer memory will be limited capacity, so they will have to make the analysis in an ongoing fashion by, supported by AI. So, in fact, it has started. You know David Saint-Jacques. David Saint-Jacques is a Canadian astronaut. He's he's simply a fabulous person. He's a MD engineer. I don't know if he's not architect. He's a jet flyer, a pilot. He's and so on and so on. But he went to the space station, as you remember. And what is he wearing? He's wearing what I call an intelligent T-shirt or intelligent garment. And this is the Astro Skin, adaptation and improvement on the exoskin, which has been introduced by a Canadian company. In fact, the company Carré Technology is in Longueuil, or just near in the suburbs of Montreal. And this company sells those wearable sensor everywhere in the world for athletes and so on and so on, and even for health, except in one country, which is Canada, because we don't have the integration of that technology in our system. So just imagine at the same time, we have in Canada, and I must say, quite proud of Montreal with Mila, which is directed by Yoshua Bengio, which has still been declared last year the most cited scientist all over the world in all sectors and disciplines. So, I mean, it's if you want a H factor here, you'll need some lines. But Yoshua Bengio and his colleagues here in Montreal have been presenting a proposal for the next CFREF application for the Université de Montréal, which is called the R3AI proposal, which is in fact proposing to develop a next generation of AI that will be much more robust, much more reasoning and responsible AI. And robust means here, and it's very, very explicit when Yoshua Bengio and his colleagues present, means applicable to, let's say, non-perfect data. And we know that health data are for mathematicians and AI experts, they're pretty dirty because there's missing things here and there and so on. And that's why AI has probably been limited in its application to the health sector. But if this R3AI project is moving on, and we should know in about 2 weeks a maximum, there will be a new AI generation or a new generation of AI. And the intention of the whole group, and there are about 1,000 professors and students, Université de Montréal, McGill, and others, and Laval University as well, along with the other superclusters in Ontario and in Alberta, we will have much more potential for those difficult to analyze currently data in AI for automatic monitoring. So if you put all this together, what about revisiting my synergistic graphic here, saying, well, first of all, obviously, the fact that deep space will need better wearables, sensors, and will contribute to have better wearable sensors, as space exploration already has been the source for our everyday life of Teflon and Velcro, which has been developed not only for space research, but has been enriched by space use. So we could think of a dynamics to have space-enriched wearable sensors. And the fact that the autonomy for deep space exploration will need AI-driven based integrated monitoring. It could be a space-enriched AI health system based monitoring. In fact, the same algorithms might be very useful to monitor people who wants to age at home. And of course, it could also contribute to the space-enriched tele-first response. So what I'm saying here is that deep space exploration, the responsibility of Canada, what is going on should obviously be put in synergy with all that we are doing at EPIC, at AgeWell, in the different universities on those e-health sensors and what to do with them. So there are opportunities. The research on the development of multiple sensors to monitor older individuals with multiple chronic disease has to be pursued and validated, and maybe benefit from the space health research or enrich the space health research, because there's lots of this work being done. So that interconnection with deep space health research could be mutually profitable, both for technologies and of course funding, because as you can imagine, there's lots of money in there. The upstream inclusion of health system deciders and providers will be crucial. And that's something that I'm sure Robin would not disagree with, because if we want such systems that will be accelerated, maybe with the synergy with deep space health and deep space exploration to be integrated in the health system, we have to include them right from the beginning. We can talk later on of the procurement challenges and so on. And so we should also include citizens, of course, older citizens, but I would say aging citizens. And I'm afraid to inform you that we are all aging currently. At the end of this talk, we'll be 40 minutes older than we were at the beginning. And so even if we are young, we should be involved, because we want to know exactly how we will be helped when we will be older, and we will want to age at home, as we saw in the first slides, which is something which is expected in the population. So because I want to leave more time for comments and questions, I'll just probably stop here. I found interesting that William Bill Shatner, the one who was the Captain Kirk on Star Trek. He himself, as an older person, 90-year-old, hopped on one of those tourist space trip, not very far away. He did go to Mars, so I don't think he would volunteer. But maybe aging at home will include space, in fact, in the future. So just on that anecdotal note, I just wanted to maybe thank everyone, thank the Canadian Space Agency for this opportunity, for having been invited on this expert group. And I really, really think that we have a unique opportunity as a country, which is seen by all the other countries as linking between deep space health challenges and contributing to the deep health space challenge, and with the Canadian government, which has, and the Canadian Space Agency, which has put in written that they will go there if it's useful for the aging population. I think we have, if we bring the health system in there, we try to work together, I think that we might have unique outcomes that will be good for all of us, because we will all end older than we are today, and maybe will be needing this service at home. Voilà, merci beaucoup.
Well, wow. Thank you, Dr. Joanette, for an incredible vision for where we could go and what the opportunities could be with respect to the role of space health in Canada as well. So I've got to say I was a bit gobsmacked myself. I've known you for a long time, but I actually didn't connect all the dots until just now. So that's just wonderful. So I'm going to take a look at the chat to see if what the questions may be. And please either put your hand up or put your question in the chat. But just to get things going, I wonder whether if there are many people in this in the chat in the session today, basically, who are involved in innovating in this space, and I wonder what advice you'd have for them with respect to their innovations and particularly the challenges of getting them integrated within the healthcare system. What would you and the potential of AI in relationship to the future autonomous nature of healthcare systems?
Well, I will not pretend having the absolute advices to all of you, because if you're innovators, you're thinking out of the box, and so I try to think out of my box. But what I see is that we have a constellation, so to take a metaphor, of conditions which are truly unique. A country that is looked at as going to be the primary helper in trying to find solutions for autonomy in deep space travel. We have a country that is recognized all over the world as being a leader in AI, a country where there's lots of research done in e-health devices and the demonstration of those devices as they help. My recommendation would be that any innovator that will be able to bring 2, 3, or 4 of those different elements together will have an advantage towards the eye of the government, towards the eye of the public health system, and that in order to do that all these main partners should be brought together upstream, because if you try to do it and come with the best multiple sensor without speaking to the Canadian Space Agency, or without speaking at the same time to the health service system, you'll end up with fabulous technology, I'm sure, but technology that will not be perceived as connectable either with the way they do it in the space or the way they do it in the health system. And so I think that my main recommendation is connect mostly. I mean, that's really the big thing, because we have lots of those elements. For instance, we have a public health system. Well, we still have a public health system, which is not the case in all countries. So this is a big advantage. It's also somewhat a challenge, because then if someone at the health system says no, well, it's if that person has a pure decision power, then it's difficult to move forward. So that's why we have to include them, to convince them and to try to conclude together. But I would say connect, and I will be happy to welcome any further comments.
Okay, well, we have a couple of questions here, and I will start with the first person who has their hand up. So that's Maria Barbosa. So Maria, it's over to you. Ask your question. You're gonna need to unmute yourself, Maria.
Yep, I'm lit. Maria?
Maria, you should be able to speak. You're unmuted. Manoush, you're up next. So Maria, we don't hear from you still. Okay, I'm not sure what's happening here. But in the meantime, while this is being sorted out technically behind the scenes, maybe Manoush and Miri, maybe you could you're also on mute.
Can you hear me?
I can now hear
Yes.
you, Maria. Thank you. Okay, there you go. Okay, so Maria, you're first, or is that Manoush? Okay, Manoush?
Okay, I go first then.
Yeah, you go first. Yeah.
Okay. Hello, everyone. Hi, Yves. I'm one of those black covers behind Yves. So it's an honor again to hear you after so many years of missing these exciting updates always about the newest like advent of technology in the research of your field. I have a concern whenever we're talking about AI, all these super gadgets, and it is very exciting, but about the feasibility, because we know that in Canada, the healthcare system has a gap. We've heard during pandemics what happened in the homes, like CLSs, like this is lack of resources just to give the basics. Let alone to all more sophisticated cares that old people need to remain independent in their homes. So are we also thinking at the same time about the infrastructure of, before giving these tools and like telepresence, robots, everything, that imagine that one day it's accessible. It's not only reserved to privileged people. Mm-hmm. But could we start first with our homes, like for more at a social level to support that? And what is the infrastructure that we will need because at the research level, we have that, the knowledge and technology, but at the feasibility of the implementation, how it is accessible and realizable.
Well, thanks. First of all, it's a pleasure to hear you, Manoush. And I know, and of course, I'm telling everyone that you're an engineer, and of course, someone who has also knowledge in neuroscience, and so you're well positioned to see this kind of challenge. Well, what you're raising, of course, is the fact that we have to have a health system that should be at least capable of addressing the basic needs, and the long-term care center disaster with the COVID has to be addressed, of course. But at the same time, the people who are, one of the challenge of the long-term care center catastrophe, so to say, or disaster, was a resource problem, a human resource problem. Mm-hmm. And I'm not saying it was only that, but it was, among others, a human resource challenge. And the same hospitals, or in Quebec we call them CLSC, same centers providing home care and helping the same group of nurses. Currently, they have to take a car or transportation, go to the place, and so on and so on. And it takes a lot of people and a lot of time, so that the deployment of a more automatic monitoring system and the deployment of a way to be tele-present if there's something in order to be there. Just imagine a nurse, and I'm just taking this as an example, a nurse who has to make sure that some people who have some challenge, they go and visit, these people in one day. I don't know, maybe there will be 3 or 4 people in the morning and 3 or 4 in the afternoon. If the same nurse is being catapulted tele-presently, the same nurse might be seeing 8 of those people in the first hour of her day. So I think, and it's not going to be harder. It's simply that it's going to focus the job on having this interaction, making sure that all the pills are present and so on. There is a video of the giraffe that I'm with on one of those pictures that shows how it works. You can have a look at it on YouTube. But so I think it could help a lot to enhance the efficiency of the system, which will release some people in order to better take care of the really urgent needs like the one you mentioned. So I think that we should not maintain the way we do it like we do it now and try to do the, let's say, long-term care center better, because we won't be able. And the person, the CEO I mentioned before launching my slides, who is not a promoter of e-health, that person, the CEO, speaking with the minister, concluded himself that there's no way we will be able to make it without e-health. So is it challenging? Of course. Is it challenging with a health system with which doesn't have yet a digital dossier médical, electronic record, medical record, EMR? Well, of course. Are we a little bit late by reference to other countries? Fully. But I think that if we don't take this move quickly, we'll just end up much more in the back line.
Okay, so there's room to stay optimistic.
Well, I'm not even optimistic. I think we cannot do it otherwise. The CEO of the hospital concluded himself he cannot do it otherwise. So it's like not even optimistic. I would say we're condemned to do it.
Okay, thank you. Thank you for answering.
Merci, Manouche.
Yes.
So I don't know, Maria has put her hand back down, so I don't know, Maria, do you want to pose your question? Oops, anyway. I guess not.
There is Mark Venning in the chat, Robin.
Okay, sorry. Perfect. Okay. Mark, basically, do you want to, so here's Mark's question. Given the current national dialogue debate about the status of healthcare as it is, what will it take to move forward the timeline to truly integrate digital health to see it more visibly active for everyday Canadians? Ooh, that's a toughie.
Well, thanks, Robin, and I think you should be answering this one because you're the expert on the health system. But I mean, you're absolutely right, Mark. We are in a large national discussion. What we hear is that we might get some good news, positive orientations in the near future about better agreement between the federal contribution and the provinces. But I'm not here to talk politics. The only thing I would say is that for a government, let's say the federal government, if a discussion can serve more than one objective, it's usually always better. In other words, if this discussion on the role of e-health to monitor people who wants to age at home it needs investment, but will mean a better wellness and people being able to age at home, and at the same time be something that will allow Canada to say to the other countries for which Canada has committed for this deep space health challenge, that it will also contribute to this, then you have two hits for one rock, and maybe it's going to be mutually helpful. So I think that the bringing together these two challenges might help bringing more resources in order to have them solutionized, more so that the basic system and algorithms for monitoring might be more or less the same, whether someone is on its way to Mars or someone is living in Mississauga and wants to live at home older.
So you got Nabila also agreeing with you on this, and I think also wondering about the sustainability of the program, and I'm not sure what program, maybe the health system itself is what she's referring to. I don't know, Nabila, if you want to comment, or if you want to comment on the sustainability.
Well, I'm not sure I want to comment on sustainability, but I think our e-health knowledge has been developed much too isolated from the health system itself. Robin and myself had the opportunity to co-chair at one point in the life of CIHR, the e-health initiative. It's now under Jane Rylett and Rick Glazier's responsibility, who are at CIHR. So we're talking about past history here, but not that far past. And what we heard is that, of course, the biggest challenge in Canada is not, again, our ability to provide technology, it's our ability to include it, integrate it in the health system. And what I was presenting today as a maybe optimistic vision, or maybe a pragmatic one, in fact, is why not surf both on the older people, who wants to age at home, and the commitment of Canada for deep space health, to have a twin motivation, a double motivation, to support research that will in fact be useful for both. So I think it's a way of moving forward and contributing to the perennity of the system, so to say.
Yeah, I think everybody's super pleased with that, Yves. I just a comment myself, actually. I think the pandemic, one of the downsides, but also upsides, is the whole crisis in health and human resources to support healthcare. And that's not, you can't change that overnight. Where digital solutions that bring high tech and high touch together, definitely are a way. And I think long-term care is definitely has to go down that pathway for sure. Well, I realize that we're closing in on the magic hour here. So I want to thank Dr. Joanette for just a fantastic talk. Wonderful to kick us off with really a big vision of where we can go with respect to both healthcare and space and technology together. So thank you so much, Dr. Joanette, for being our inaugural speaker for this particular series of seminars. Thank you very much. And thank you everyone for your kind attention and questions. We'll look forward to our next session.
Thank you so much to everyone. Thanks for your questions, and don't hesitate. I have a publicly known email, so if you have comments, you can email me.
Bye, everyone.